Welcome, listeners, to Ray Dionandan's Global Health class, HSS 4331. We have a special presentation today from a former student in this class, Ms. Emily Paterson, who went on to study public health at the University of Alberta, I believe. If I'm wrong about that, she'll correct me. And she's now doing wonderful things up north in Sioux Lookout. So I don't want to take up too much of her time. So I'll hand it over to you, Emily.
Okay, great. Thank you. So I'm here to talk to you about our approaches to community well-being, which is our public health system at the Sioux Lookout First Nations Health Authority. So just a little bit about me. I'm the Director of Approaches to Community Well-being at the Sioux Lookout First Nations Health Authority. I studied at the University of Ottawa doing a Baccalaureate of Health Sciences, and I was in Ray's first global health class. So following that, I did a master's in public health from the University of Alberta, so he got that right. And I specialized in global health. I've worked in East Africa, in Tanzania, Kenya, Uganda, and also in South America in Guyana. So now I'm working with First Nations in Northwestern Ontario, and a lot of the issues are quite similar between the First Nations communities and some of the work I've done abroad. So I'm going to do a brief overview of the state of First Nations health in Northwestern Ontario. I'm not going to bog you down with really stats or anything like that, just to give an overview. So the social determinants of health are very prominently affecting our First Nations in Northwestern Ontario. So there's issues of overcrowding and poor housing quality. So for example, with the housing quality, we have a lot of mold issues, bed bugs, and cockroaches in the community. With overcrowding, we will often have houses of 15 people living in one small house, so that they actually have to take turns and shifts sleeping in the beds. Most of our communities currently have boil water advisories. Some of our communities have been on boil water advisories for over 20 years. And then the cost of fresh food is very, very high. And then the selection of produce isn't very good. And by the time it gets into our communities, it's often almost going bad, which also affects the cost. So here are some examples of, in one community, this was their fruits and vegetables selection. Not a very large selection for a community. This is another community's selection of fresh produce. And then this is the milk supply. So I don't know if you can see it, but 4 liters of milk in this community was $16.99. And I've seen it over $18 in communities. As a result of the unavailability and inaffordability of healthy foods, we have higher rates of diabetes than elsewhere in the province. We also have high rates of infectious diseases, including TB, hepatitis C, and skin infections. So in most of the population of Canada, TB is virtually non-existent, but we have higher rates. We also have rheumatic fever. We've had several cases of rheumatic fever, which once again is something only really associated with developing countries. We also have lots of mental health and addiction issues in our communities, and many of our communities are currently experiencing suicide crisis. So the way health services are offered in the community is that nurses provide the bulk of the health services. Physicians travel into the communities for a few days to a few weeks a month, depending on the size of the community. Dental services are provided in the community only a few times a year, so they do not meet the needs of the community, and they focus mostly on they focus mostly on treatment, so extracting teeth, because there's not enough service provided. There's not really the time and resources to do all of the preventative screening work that needs to be done. For any specialty services, the First Nations must leave their community and travel. So that's included for, childbirth. Women have to leave the community a few weeks before their due date and wait in a hostel to deliver birth or to deliver their baby. Also, for any sort of tests like MRIs or mammograms, they have to leave the community. And also, if a woman or a man is sexually assaulted in the community, they would need to leave their community in order to get a sexual assault kit done. So First Nations health is also affected by systemic and individual barriers. So our communities face jurisdictional issues and gaps. This occurs when federal and provincial governments argue over whose responsibility the healthcare is. So Jordan's principle, I'm not sure if people have heard of it in the media, but it's a child first principle that was named in memory of Jordan River Anderson. He was a First Nation child from Norway House Cree Nation in Manitoba. He was born with complex needs and spent more than 2 years unnecessarily waiting in hospital while the province of Manitoba and the federal government argued over who should pay for his home care. He died in the hospital at the age of 5 and had never spent a day at his family home. So Jordan's principle aims to make sure that First Nations children get access to public services ordinarily available to other Canadian children without experiencing any of these service delays or denials related to their status as First Nations. So the principle is whoever encounters the child first pays for the system, and then the care, and then the governments argue it out later. Our communities also, and First Nations also experience inequitable policies that affect their health. So I have some examples in the media here as well. So for example, around prescriptions, First Nations can wait weeks for the approval of their prescriptions. And then in terms of travel, they're not compensated the same way as the public or the provincial system. So for example, in Northern Ontario, if you need to travel to visit a specialist, all you need to do is have your physician sign a piece of paper indicating who they are referring you to, and then the doctor you've been referred to needs to sign it to say that they've seen you, and then it will get reimbursed. However, for First Nations, all travel must be pre-approved, and the physician is required to put personal health information on the form in order to justify their referral. They're often denied services by a clerk who has no medical training. So recently, the physicians that service our communities took a stand and said they will, from now on, refuse to put personal health information on the form. So that's the issue that is in those two links there. Our communities, obviously, from what I've said, have insufficient resources at the community level, and First Nations are often affected by healthcare provider attitudes and biases. So if you're interested, this link provides a video that is about a man who is doing a healing journey home in honor of his wife. So he walked from Thunder Bay to his home community to raise awareness about the insufficient resources at the community level. So his wife was experiencing an illness and needed oxygen, and there was not enough oxygen in the community, which deteriorated her condition. And then she was in hospital in Thunder Bay, where she experienced racist attitudes from staff and was often ignored, and unfortunately passed away. So in terms of public health, the resources allocated to public health are limited. Health Canada, who's responsible for health on reserve, does not provide public health services, and the province, who is responsible for public health, does not have the mandate to work on reserve, which again provides this jurisdictional gap where the First Nations fall. Our communities go from crisis to crisis and do not have the time or resources to allocate to public health. The community-based workers are dedicated and want to help their community to be healthy, but they lack the needed support. But I don't want you to think that it's all negative. There are lots of positives too. So the staff in our communities, the health directors and the community-based staff, are very hardworking and dedicated. The community members know the issues and they already know the solutions. They just need people to listen and to enable them to move forward on them. And our communities are building traditional and land-based activities into their programs, which is promoting healing. There are also lots of different community initiatives that vary from community to community. So I've put a link to an article about a nutrition initiative, which was a community garden in North Caribou Lake First Nation. There's also a lot of humor. You can see there's any meetings we have, the staff are always laughing, and our communities are very resilient, and the First Nations people are very resilient after all they have been through and continue to face. The resiliency is there, which is very inspiring. And of course, the communities are beautiful. So I put in a few pictures so you can sort of see where we're working. So the Sioux Lookout First Nations Health Authority was developed after a hunger strike in 1988. So on January 18th, 1988, 5 men from Sandy Lake First Nation went on a hunger strike to protest the deterioration of equitable and quality health care for First Nations. After that strike ended, a health panel comprised of Archbishop Ted Scott, Wally McKay, and Dr. Harry Bain were tasked to document and analyze the health care problems in the Sioux Lookout region and recommend solutions to help Anishinaabe Nation and the federal government improve health care delivery. One of the recommendations from this report was to develop a First Nations health authority that would develop health policy for the Sioux Lookout region and control and administer health services centrally. This led to the Sioux Lookout First Nations Health Authority, which was established in 1990. We service 33 First Nations communities and play a role in providing health services, advice, and advocacy. This is a map of the communities we service. 80% of our communities are fly-in, and most of those are, however, accessible by the winter roads. However, due to climate change, we are seeing the winter road season decrease, which is affecting the ability for communities to get access to food and building supplies, and also decreasing their ability to move from community to network and see friends and family. Our organization is governed by the chiefs of our community. So once a year they meet at an annual general meeting and pass chiefs resolutions that give us direction. And then throughout the year we have a chiefs committee on health, which provides direction and guidance. And then we also have a board that's made up of representatives from the communities. Our organization provides mental health services. We have counselors that either live in or travel to the communities. We're also contracted to provide physician services. So we contract the physicians who travel into our communities and arrange their travel and their support. We also run a Northern Appointment Clinic based in Sioux Lookout. So this is the first kind of referral point. So if clients need to see a physician outside of the community for care that can't be in the community, they go to this clinic. We also provide developmental services, mostly through telemedicine, to children with disabilities and a transition program for them into adulthood. We have a client services department which provides transportation, accommodation, advocacy, and translation services for clients who come to visit the Northern Appointment Clinic or the hospital in Sioux Lookout. And then most recently, we now have the approaches to community well-being, which I will talk about. right now. So the approaches to community well-being came out of the Anishinaabe Health Plan, which was a plan our organization developed in 2006 to outline how health services should be provided to our communities. And then in 2010, there was a public health services assessment that identified what currently was happening in the communities related to public health. Also in 2010, our chiefs passed a resolution. Did you want, Ray, you're waving to me.
No, I'm just killing time. Go, keep going.
Oh, in 2010, the Chiefs passed a resolution mandating SLIPNA to develop an integrated public health system for our communities. And in 2012, we received a Health Services Integration Fund grant from Health Canada to develop our public health service. As part of the development process, we did an environmental scan of other First Nations public health systems in Canada. And then we updated our public health services assessment. In 2010, it only included 10 communities. So we updated it to include another 18 communities. And then we went through a process of community engagement to hear what communities wanted in terms of their public health system, their vision, values, goals, and the programming they needed. And then we took that feedback and worked with First Nations members of our working group and developed our model. In 2015, we presented this model to the chiefs and they approved it. So the reason we call it Approaches to Community Wellbeing is because public health really didn't resonate in the communities. So our communities don't speak about the public, they talk about their community or their community members. And then with the word health, they associate it with going to the nursing station. And even when they talked about how they would translate it into their local languages, they talked about explaining going to see a nurse, which was not exactly the message we wanted to give with our public health system. We also just didn't like the word system, so we changed it to approaches. So now we have approaches to community and then well-being to show our holistic view of health. So Approaches to Community Wellbeing is an integrated model for public health service delivery. It's a regional model to support 31 First Nations communities. So our organization, I said, had served 33. Depending on the funding source, we service anywhere between 28 and actually 39 communities. So the funding for this system was for 31. It's an adaptable model to meet the needs of communities. The vision of the system is that the Anishinaabe people of this land are on a journey to good health by living healthy lifestyles rooted in our cultural knowledge. We developed a series of values. The first is the teachings of our people. Our communities are very diverse. Some of them are more traditional and may follow the 7 grandfather teachings or elders teachings, whereas others are very Christian-based. So in order to accommodate all of those viewpoints, we just said the teachings of our people. So whatever that is for the community would be what those teachings are. Other values we have is language, history, family, holistic, honor choices and respect differences, share knowledge, connection to the land, and supportive relationships and collaboration. We've developed some very broad goals for the system to help us develop the programming areas. These goals would have to be further defined in order to be measurable and also adapted to each community. Overall, our goals are to have improved approaches to community well-being, which are integrated, holistic, sustainable, and proactive. Increased community ownership over our health and approaches to well-being. Increased number of people leading the way who are committed to healthy communities, safer communities, increased number of people making healthy choices, increased number of children raised as healthy community members, and increased connections to the teachings of our people. So when we hosted some of our meetings and went into some of our communities, we used a graphic recorder who drew and wrote down what we were talking about, which really helped in engaging people. So this is one of the images that came out of our vision, values, and goals session. And this is our model for approaches to community well-being. So the values are at the center. And then we took our goals and realized that some of them spoke to more program areas, which are the raising our children, healthy living, safe communities, and roots for community well-being. Whereas other goals sort of spoke to how the system needed to run. And they're both needed for the system, but also would be improved by the public health system. So those are surrounding the model, which are teachings of our people, active leadership, community ownership, and positive people. So we further defined each of these main program areas. So raising our children includes family health, youth development, and building healthy relationships. Healthy living includes preventing chronic diseases and preventing infectious diseases. And safe communities includes environmental concerns, preventing injuries, and emergency preparedness. And roots for community well-being includes data collection and analysis, planning and evaluation, research, ethics, policy, capacity building, and communications. So I'll go through these in more detail. But first I wanted to talk a little bit about mental health. Mental health is a critical component for our communities, but the decision was made not to include it visually in the model. We thought if we were honoring the holistic approach, then we couldn't separate out mental health, but rather mental health would be under each program area. The way we represented this was, if you look in the smaller circles on each of the four corners, in the center where it says raising our children in our safe communities, for example, there's 4 white lines, and that illustrates the physical, mental, spiritual, and emotional well-being. So that's how we visually represented mental health. So currently, in regards to mental health, we support communities in their response to opiate addictions, provide training and workshops in areas of mental health and family healing and resiliency and reconciliation. Under raising our children, we have family health, youth development, and building healthy relationships. In family health, this would include programs such as prenatal classes, the promotion of immunizations, promotion of breastfeeding and infant feeding, early childhood development, attachment, and also oral health. In youth development, this was an area that became a priority for communities. Most of our youth have to leave their community in order to go to school. Most of our communities, the schooling only goes up to grade 8. We have a few communities who have up to grade 10, and just, I think, one community that has it all the way to grade 12. So we did work on youth development in more detail to date, as we do a phased-in implementation approach. So our vision for youth development came from a lot of youth engagement activities, and it's that the Anishinaabe youth are connected to family, community, and culture, and are engaged in activities that promote resilience and well-being. The youth developed a bunch of values they felt were important, many of which are also included in our model, but they included land-based activities. They had friends, and education and sports were sort of unique. They also, if you can see on this word cloud, they came up with some of the teachings of our people, or the grandfather teachings, like honesty, trust, and bravery, and respect and truth. The goals for the youth development section are that youth minds are engaged and working towards a positive future. Youth have a strong voice. Youth are living healthy lifestyles. Youth are following in the footsteps of their ancestors, and youth have healthy relationships. So far what we're doing in the youth development section is we have a Facebook page called the Anishinaabe Youth Network, where we're sharing youth events and information about well-being, community well-being. We're also working to advocate and support youth councils, so the development of youth councils in communities. We will provide resources and training for youth workers and support a youth development advisory group that will continue to guide our programming. And with the youth workers, we're looking at creating a network so they can communicate and share ideas and challenges and solutions. So with building healthy relationships, this will look at things like the relationship you have with yourself, so self-esteem, body image. It will also include relationships to culture, land, and spirituality. It will look at peer relationships, so anti-bullying campaigns, romantic relationships, parenting, relationships with elders, and then community relationships. Parenting is a very important relationship, as throughout history with the residential schools, generations have lost their traditional parenting methods, and so we're looking at how to restore that. For healthy living, we have preventing infectious diseases and then preventing chronic diseases. Preventing infectious diseases looks at health promotion and harm reduction. It will also look at the case and contact management of reportable diseases. We currently provide a Hep C support and treatment service, and we'll also be looking at addressing or developing strategies to address key issues in our region, such as skin infections and rheumatic fever. Preventing chronic diseases will tackle lifestyle factors, including physical activity, healthy eating, tobacco cessation, and substance abuse, and we'll look at the promotion of chronic disease screenings. For safe communities, we have environmental concerns, preventing injuries, and emergency preparedness. This will look at how environmental concerns impact health, so the issues of housing, water quality, and food safety inspections. We want to support communities to build capacity around these issues, such as food safety training, water testing, and then supporting plans to correct these issues. So currently, the way environmental health works is that Health Canada has environmental health officers, which work similarly to public health inspectors in the provincial system. They will fly into the communities and inspect food premises, the nursing station, and sometimes housing, but they have no authority in the implementation. So they'll write recommendations of what to do or what needs to be done, but they have no authority. So if there is a food premise that is unsafe, they don't have any authority to close it down. So in theory, it can stay and continue to be a threat to public health. There's also new resources to help support communities in responding to these issues. So in areas of like bed bugs or cockroaches, for example, there's no real resources to help address those issues. So we haven't started implementation of this area yet, but it's something we're looking at doing over the next year or two to determine how we can build a more supportive response to environmental concerns. For preventing injuries, we'll look at preventing the injuries and deaths through health promotion, as well as working with a policy analyst on policy solutions or band council resolutions. So this could be around seatbelt use, life jacket use, smoke alarms, and preventing falls. Suicide and self-harm prevention would also fall under here. The challenge on reserve is that the way their bylaws work is through band council resolutions. So chief and council pass a resolution. For example, they could pass one on making seatbelt use mandatory, but there's no one really available to enforce that. So the police on reserve do not enforce band council resolutions. In emergency preparedness, communities do receive a small amount of funding to support emergency preparedness planning. So the SLIFNA approaches to community well-being can provide communities with support with these plans and with responding in cases of emergency. So for example, our environmental concerns team could support planning around any environmental emergencies, whereas our preventing infectious disease team would help support around infectious disease outbreaks, for example. And then we come to Roots for Community Wellbeing, which looks at all the different areas that are really needed in order to support the other programming areas. So for data collection and analysis, currently in our communities, no one is responsible for health status reporting. First Nations data is housed in a variety of provincial and federal databases. And SLIFNA has been mandated through Chiefs resolutions to conduct health surveillance and enter into data sharing agreements on behalf of communities. But so in the province, the health units generally do health status reports or health surveillance. Health Canada does not do this on reserve. And then the First Nations data that's housed in provincial databases is often suppressed from the provincial public health units or local health integration networks in order to respect OCAP principles, which I'll get into in a second. But then they won't also share that information with First Nations, which means that no one is analyzing First Nations data for health surveillance purposes, which means they are not getting equitable services. So abiding by the principles of OCAP. OCAP are 4 principles that can't really be separated out. They come together. They were developed by the First Nations Information Governance Center, and they guide how any community information should be used, whether it's teachings or stories or health data for research or surveillance. So ownership refers to communities owning their data like an individual owns their personal health information. Control refers to the First Nation community having control over who collects, analyzes, or discloses or stores their community data. Access refers to communities being able to access their data whenever they want to. And then possession refers to the actual physical possession, so storing where the data is stored. So to abide by OCAP principles, it does not need to be stored in the community. A community could appoint an organization to be their steward of the data. So through the Chiefs resolutions, they have acknowledged that our organization is the steward of their health data. So we've hired an epidemiologist to support data collection, analysis, and dissemination of reports. We've been currently negotiating data sharing agreements to gain access to databases and to return First Nations data under First Nations governance. This has been quite a process, and we've been negotiating with one database for over a year now. We're also undertaking community engagement to determine what indicators are significant to communities and to develop wellness indicators. So we want to ensure when we are developing health status reports that we do have indicators that make it comparable to other First Nations or to the province. But we also want to make sure that we're tracking indicators that are important and interesting to the communities. We also find most indicators are really illness measures or the lack of illness. And we wanted to flip that around and look at what wellness indicators are. So we're doing engagement into the communities to talk about what would they measure if they were measuring the actual wellness. So we've heard about how many people are attending cultural festivals, how many people are hunting out on the land or trapping or fishing, how many people are relying on traditional foods, which are obviously a lot harder to measure. For planning and evaluation, sorry, there's a typo. We offer support to our organization, the tribal councils and communities in public health and program planning, as well as to evaluate our own initiatives and support communities in their program evaluation. We have a full-time planner position at SLIFNA, and then we have community well-being facilitators to support community engagement around planning. So these positions, we have one at SLIFNA, and then the idea is to have one at each tribal council. We have 5 tribal councils in our area. Each of those support 4 to 6 communities, depending on the tribal council. And then we have 2 independent communities, which each are also getting a community well-being facilitator. So we're under recruitment for many of these positions now. And the idea is this role will work with communities to identify what the approaches to community well-being looks like at the community level. So there's a variety of programs at the community level, but what they do in each community varies. So there's a program funded by Health Canada called Aboriginal Diabetes Initiative. And in some communities, that worker might be working on physical activity programming, a community garden, and diabetes education, and would very much fall under our approaches to community well-being. Whereas in another community, that person might be focusing on clients who already have diabetes and helping them manage their diabetes. So these positions, the community well-being facilitators, are meant to determine how the approaches to community well-being is structured at the community level, and what gaps there are that we need to then look at how to support from the regional level, or how to advocate for additional positions at the community level, and what the training needs are so that our organization can respond. With research, the Sioux Lookout First Nations Health Authority and the Sioux Lookout Menayawan Hospital have developed a partnership for the Anishinaabe Bemadzwin Research Unit. Approaches to community well-being will support the research unit and the communities to identify public health research questions. And also, this research unit needs to follow OCAP principles as well. In the ethics section, we're just looking at making sure everything is done ethically. So the research and biomedical ethics are very different from public health ethics. There are several different public health ethics frameworks that exist, but they might not be in line with First Nations ethics. First Nations ethics are more based in traditional teachings, so we need to develop what a First Nations public health ethics framework would look like for us. For policy, as I mentioned, we want to support healthy public policies, which might be through bylaws, which are called band council resolutions. But as I mentioned before, few, if any, resources are available to enforce these band council resolutions. Some communities don't like the idea of bylaws or band council resolution or policies, and they prefer to focus on traditional teachings as ways of encouraging policies. For capacity building, we want to look at building the capacity of the health workers as they currently have limited training. So many workers will start in the community without any orientation and maybe get a workshop a year. So we want to look at training certifications or modules or workshops, train the trainer approaches potentially, mentorship models, and then providing resources and workbooks and guides for them. Communications is a very broad area of our model because it looks at the communication materials for health promotion and how best to do that. So we're currently doing a survey to find out what the best way of reaching people is, whether we don't want to produce tons and tons of posters and pamphlets if no one's reading them, if it's better to make videos or use pictures or whatever it is. But communications also includes trying to improve the communication between stakeholders. So that could be the communities and our organization and the tribal councils, between the levels of government as well. And then one thing our communities wanted was the ability to network with each other and learn from each other, so that if they're having issues, they can discuss them and see how different communities have approached them. Our approaches to community well-being is guided by our working group, which is made up of tribal councils and independent communities. They oversee the ongoing development, transition, and implementation of approaches to community well-being. They also ensure that we are doing things in a culturally appropriate way, so that our programs and materials reflect that. And they share with us their perspective and their community's perspectives. We also have a negotiations table. This is made up of representatives from federal and provincial governments, the public health units. So our area is actually serviced by two different public health units, the Thunder Bay District Health Unit and the Northwestern Health Unit. And then we have a representative from our Chiefs Committee on Health, our organization, our working group, and then the Northwest LIN. The purpose of this table is to negotiate jurisdictional and legislative barriers and to get us negotiate sustainable funding. So we're currently doing a phased-in implementation approach. So as I said earlier, we currently offer mental health services. We also offer preventing infectious diseases services. So we have a hepatitis C support and treatment service. We currently do the follow-up for tuberculosis. We also have a needle distribution service that is mostly like a supply chain. So we provide all of the needle distribution kits up to the communities, but we're currently undertaking an evaluation of that service in order to determine how we can better support communities in the delivery of their needle distribution service. Most of the communities run it out of their nursing station, but depending on the nursing station, they sometimes have restrictions in place of how they can access it. So they might offer it only 1 hour a day, which is quite challenging. We're also supporting the communities with planning. And we have one youth facilitator that's starting to do the work in youth development. We're beginning to access data sources to provide epidemiology services. So we actually just got access into our first database on Friday. So we'll start to be able to analyze some data, which is really exciting. As I mentioned, we're beginning the implementation of youth development, and we'll be expanding quite a bit over the next few years as we transition and take over more and more of these public health services. So for any graduates, there's lots of recruitment possibilities in the future if you're looking. That's all of my presentation. Miigwech, thank you. There's my contact information and our website and our Facebook page if you would like any more information.
Thank you, Emily. Can we see your face as well? You turn that off?
How do I turn it off?
Go to show. Oh, look at me now. That's weird. Okay. Now we're stuck looking at me. That's no fun. Stop sharing screen. That'll do it.
Screen.
That should do it.
And don't mind me, I'm at a hotel in Thunder Bay right now, traveling a lot.
Probably, it's better internet than I have right now. We're still stuck looking at my face. Well, while we're stuck looking at my face, I wanted to ask you 2 questions, if I can. First question is, what is the biggest challenge, do you think, right now in First Nations health where you are?
One challenge is very hard. I would say probably mental health, but I also think the social determinants of health really underline mental health a lot. So I think it's hard to tackle mental health without housing. I was just in a community last week where only a quarter of the houses had indoor plumbing, and they had 15 people living in each house sleeping in shifts. And I think, how do you tackle mental health issues when that's what you're living in and you're sort of in survival mode?
And yet mental health is not in your framework, right? Not in the logic model that I saw?
It's in there. It's just in there from a holistic perspective. So in every area, we're looking at physical and mental, emotional, and spiritual well-being. So for example, in preventing infectious disease or preventing injuries, we're looking at suicide prevention and self-harm prevention. In building healthy relationships and youth development, we're tackling a lot of the sort of building a network and support system that would sort of underscore mental health.
Okay.
And we have other mental health supports that sort of work with the different areas and partner with those areas.
So the reason I was waving earlier is because I'm using a screen capture program, and looking at your slides, you can see the slight corner of my window, and I was waving to get my fingers in the window. That was the reason. And I forgot that you could see me also, so now it's a little awkward. but my second and last question is, because you have experience working in Guyana and parts of Africa, so clearly you're a seasoned global health traveler and researcher, and now you're in the Canadian North. What are the main parallels between Northern Canadian work and developing world work that is relevant for the entering student in global health studies?
I think my work overseas prepared me very well, like to work in a different cultural context. So working in First Nations communities, it's a very different culture, but very different culture from sort of the rest of Ontario. And so that parallel of working in different cultures in Guyana and East Africa and up north is definitely there. Even just little things like going in East Africa, every time we started a meeting, we prayed. And every time we ended a meeting, we prayed. And without that, I don't know if I would have really been prepared for that within Ontario, right. That every meeting we have. I think in terms of like the infrastructure in our communities, it's maybe not as bad as what I've seen abroad, but there's the issues of power outages. So the community I was in last week, we had no power for 24 hours and no cell service or no phones at all for 42 hours. And so living in those sorts of conditions, the difference being it was really cold as opposed to being on the equator. And then I think infectious diseases is very, very similar. We have, due to the overcrowding in our communities, we can see infectious diseases spreading quite a bit. We also have infectious diseases and complications from them that you don't see elsewhere in Ontario. So we still have many active TB cases, and we have like hepatitis C soaring, but also things like rheumatic fever, which is a complication from strep throat that I didn't even really realize could happen until I was up in northern Ontario. I think one of the other when I worked abroad, I worked mostly with maternal and child health, and one of the challenges was always getting a skilled person to deliver babies and getting mothers out to facilities that were well equipped. And I think that's a similar situation where there are nurses in our communities, but women do have to leave their community about 3 weeks before they're to give birth. They don't always get to take an escort with them, or the escort, like a funded escort. So if their family can't pay, then that woman's 3 weeks alone about to give birth, which is a scary experience, I imagine. And they will stay in the hostel that we provide. We have basically it's like a hotel that we have for women and other patients that need to come down.
Right.
So that's also a challenge you see when I was in global health and looking at models in East Africa. They had the little huts or birthing homes set up for women to be able to stay there. The same issues faced with the woman maybe not wanting to do that because then she has to leave her kids and everything behind. And then one of the biggest parallels, Our communities have a lot of health programming that is run by community members that aren't trained. And we actually, another initiative that the Sioux Lookout First Nations Health Authority is doing is looking at a community health worker model. So they actually were funded as a research study and looked at models in Africa and Australia and the US of training community-based people to do a little bit more outside of their scope. So we're looking at that as a model in our communities, but focusing on diabetes.
Cool. By the way, your screen is so frozen with my ugly face on it. Is that what you see as well? Or do you see something else?
I
Really?
see myself. I see myself and you, but it's
No,
not
I just see
frozen.
me, which, okay, maybe that's okay with you. I don't know. But before you go,
Well, I don't know how to take it.
maybe,
Turned off your screen. Like I'm not sharing my
yeah,
screen
that's weird. I
anymore.
don't want to mess with anything in case we turn this off. But since we're almost done, let me ask one last question then, if I can. Is if the viewer doesn't mind looking at my face still. The question is there a difference between Northern health and Aboriginal health?
Um, well, I mean, academically, Aboriginal health is First Nations, Inuit, and Métis, and I'm working in just strictly First Nations. I think Aboriginal Northern health. I don't know if it's actually. I think to me, Northern health is more about the remoteness as well.
Okay.
Um, and Aboriginal health could be looking at on and off reserve.
Okay.
So I don't really know what you mean by
It's a
Northern
safe
health.
answer.
Northern health could just be living in the north and not on reserve too,
Right.
maybe.
That's a possibility. I'll have one last effort here to put your face back on. And oh, I'm stuck with my face. So I hope this recorded, because I know you're not going to do this again. So let me thank you officially and invite you to come down to Ottawa to do this in person anytime you like. Otherwise, I'm going to stop the recording now. Don't go anywhere. I'll stop this recording and see